We have been asked at intensive care at home if care can be provided at home for a long-term ventilated 85-year-old man who's currently in ICU for a few months with ventilation, tracheostomy, and other complexities. We will break that down today in this video. My name is Patrick Hutzel from intensivecareathome.com, and we've got an email from a client who's also part of our membership for families of critically ill patients in intensive care. And you can have a look at that at intensivecaresupport.org or go to intensivecarehotline.com and click on the membership link. So anyway, this is an email from one of our clients in our membership who asks, our dad has been in ICU for 3 months now. He's on a ventilator with a tracheostomy. He's got a history of necrotizing pneumonia and recurring pneumothoraxis. He's on a PEG tube. He's got hypotension. He's got chronic kidney disease. And he has been passing some spontaneous breathing trials. Can intensive care at home take him home? He's also got contractions. He's got multiple pressure sores on his back, on his heels. He's quite sick, but we no longer want him in ICU. He's getting depressed, and this is not the right environment for our dad, especially since the ICU is almost wanting to give up on him. We feel like he's much better off at home. So let's look at this in more detail. Obviously, like I mentioned, he is ventilated on and off. He has been passing some spontaneous breathing trials, but he's sort of alternating between the TracheShield/TPs, between CPAP on a PEEP of 5 and pressure support of 6 on 30% of FiO2. He's maintaining tidal volumes above 300, but there's also times when he needs to go back into SIMV, where he can't breathe by himself at all. He's also on multiple anti-pain medications such as acetaminophen, oxycodone, and morphine. He's got intermittent hypotension with low blood pressures on 85/55. He's got hypernatremia, which is also known as high sodium, high blood urea levels, which is treated by free water because he's dehydrated. He's also getting IV fluids to again manage the hypernatremia because again he's dehydrated. He's got no temperature. He's just completed a course of antibiotics for the recurring necrotizing pneumonia. He does seem to be in a lot of pain, again, because of the pressure sores, the contractions, as well as the necrotizing pneumonia. They've decreased the metoprolol, which is an antihypertensive medication to reduce the hypotension, the low blood pressure. It's now down to 25 milligrams twice per day. Might still be too high if his blood pressure is only about 85/55. Blood pressure does improve with fluids because he's dehydrated. Now, the ICU wants a do not resuscitate order for this gentleman, but it's really not up to ICU to make that call. It's up to the family or to the patient whether they want a DNR or not. He does have a PEG tube in situ, and he's on high-calorie diet feeds and low sugar content formula because he is also diabetic and insulin dependent. His hemoglobin at the moment is at 8.4, which means if he is going home, probably would need a top-up so he doesn't bounce back into hospital for needing a blood transfusion. Normally, blood transfusions are given for a hemoglobin less than 7. But he might also benefit from having more nutritious feeds and iron infusion or iron supplements, vitamins and minerals to, again, get the hemoglobin levels up. The goal from a ventilation point of view is, of course, to continue weaning him off the ventilator, increase the time on the TracheShield or TPs, and maintain tidal volumes greater than 300 mils and with a breathing rate of between 10 to 30 breaths per minute. And obviously, if he can't tolerate the spontaneous breathing trials or the CPAP, he should go back on the SIMV mode. He does need suctioning as needed. He is on albuterol nebulizers 6 hourly, and he just completed a 6 weeks course of antibiotics for the necrotizing pneumonia. And that's probably one of the main reasons why he can't come off the ventilator just as yet. He also continues to have right upper lung zone consolidation concerning for new cavitation, especially given the history of necrotizing pneumonia and a history of right recurring pneumothoraxes. And therefore, his prognosis from the intensive care team's perspective is rather poor. And whilst the family can be accepting of that, they do not want for him to stay in ICU, and they do want to go home. So what needs to happen next? Well, what needs to happen next is someone needs to, pay for home care, which is, by the way, much more cost effective than the stay in intensive care. And the cost of an intensive care bed is around, nowadays $5,000 to $6,000 per bed day. And in an environment where ICU beds are in high demand, this gentleman has been in ICU now for about 3 months, and the family wants him to go home. So the funding body, whoever that might be, depends on whether there's private health insurance, whether there's aged care, aged care funding. It's half of the cost of an ICU bed, and the ICU needs the bed anyway. So it's a win-win situation for everyone. And while we're on the topic of aged care, aged care funding in Australia in particular needs to improve big time. It needs to move towards an NDIS type model, because we can't discriminate between NDIS participants and aged care participants. It's discrimination. We can't discriminate against our elderly, and we need to offer them the same level of care. And for example, NDIS participants get when they are in difficult health or in difficult disability situations. Our hospitals are bed blocked with aged care recipients, and they need to be able to get home as well, similar to NDIS participants. This is discrimination, and it needs to stop. And I do understand, and I hope that the Australian government, federal government, I should say, is moving towards more aged care funding to get patients out of hospitals and let them go home with dignity and with the right services that they need, want, and deserve, of course. This gentleman here also has Alzheimer's disease, diffuse cerebral atrophy, and chronic changes, chronic metabolic encephalopathy, and life-limiting MRI brain without acute changes, punctuate cerebral gradient foci consistent with amyloid angiopathy and additional punctate foci in basal ganglia, common for chronic hemorrhage. So, he's also had a brain bleed, basically. Moderate to advanced atrophy with temporal lobe predominance and chronic small vessel disease. So, so there's definitely some brain issues as well where he may not wake up, but, even if this is developing into a palliative care situation, potentially, this man will be so much better off at home. And the ICU will be so much better off of having this man at home with intensive care at home, because they can free up the bed for someone who's in need of acute critical care, right? So once the funding is organized, then we can look at organizing equipment for home care, 2 ventilators, 2 suction machines, 2 monitors, nebulizer machine, spare tracheostomies, emergency kits, hospital bed, air mattress, hoists, either ceiling hoists or portable hoists, wheelchair, and then create a team around this gentleman, which, is a much more stable team, generally speaking, than in a hospital. In an ICU, people come and go, whereas, our goal is always to create teams around clients that the clients are satisfied with, teams that want to work with a particular client. So, and like I said, home care for, patients that are above 65 and do not qualify for the NDIS needs to be made available as well. As some of you might know, Currently, the Australian government funds around $60,000 per year maximum for aged care packages, which is nowhere near enough to get enough patients out of hospital, especially if they need services like intensive care at home that can save massive amounts of money for departments of health or for private health insurances. So with intensive care at home, we're currently sending our critical care nurses into the home 24 hours a day. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, but also for adults and children with tracheostomy and without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing ventilation weaning at home. We're also providing central line management, peak line management, Hickman's line management, as well as port management at home. We're also providing nasogastric tube and PEG tube management at home, as well as palliative care services at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, the In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going into the emergency department. Therefore, we're also in the position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per day. We're freeing up the most sought after bed in a hospital, which is the ICU bed. But most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are currently the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025, and we have been achieving this level of accreditation since 2012. No other provider has achieved this level of accreditation in the community and has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. And if you're at home already and you're watching this and you realize you don't have the right level of support, or if you're stuck in an ICU long term, or if your family member is stuck in an ICU long term, I'll give you a real world example today. One of our first clients about 10 years ago when we first got started was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, it's dangerous and negligent having support workers looking after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies or even dying if they don't have a team of critical care nurses looking after them 24/7. This is actually evidence-based that in the community, it's documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com, where it's clearly documented that only and exclusively critical care nurses with a minimum of 2 years critical care nursing experience can look after ventilation, tracheostomy at home safely. Think about it, in an intensive care unit in an ICU in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? People have died because of this support worker model. So eventually this client found out about us, the ICU that he was going back to found out about us, and we were proving our concept with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again. and we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients, otherwise we would not be in business. The same is applicable for those stuck in an ICU, similar to our case study. To what you're looking for, reach out to us, we'll make it happen for you as well. We can take you through the right steps. And that is also why we're providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators. I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. And if you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. If you're a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years pediatric ICU ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I have a disclaimer, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients do want the same staff coming over and over again, because they're very vulnerable and very special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We're looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts. And if you're really keen on building relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can help you eliminate your bed blocks in ICU and ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is much more cost-effective than what you're paying in ICU and ED for, and you get the same level of care and you're freeing up your beds. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, home TPN, of course, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.